All right, good afternoon, everyone. We are delighted to welcome you to the first Zaremski lecture of the spring semester. I am Professor Sharona Hoffman, and I'm the co-director of the Law Medicine Center. We are grateful to our donors, Miles and Elena Zaremski, whose generosity enables us to have these events. Our Zaremski lectures connect our law school community with some of the most prominent and accomplished health law scholars in the country, and today is no exception. We are extremely fortunate to have with us Professor Erin Brown from Georgia State University College of Law, and she will be speaking about private equity and the corporatization of health. Before I introduce her, just a couple of administrative things. We'll be taking questions at the end of the program, and if you have joined us virtually, please put your questions in the Q&A, not in the chat. Somebody will be monitoring those. And if you are seeking CLE credit, the code will appear later on towards the end of the program, and that will be in the chat. Professor Erin Brown is the Catherine C. Henson Professor of Law and Director of the Center for Law, Health, and Society at Georgia State University College of Law. She received a JD from Georgetown, an MPH from Johns Hopkins, and a BA from Dartmouth College. She specializes in health law and policy, and her research focuses on healthcare markets, consolidation, and cost control. Professor Brown has published articles in leading legal, health policy, and medical journals, and has served as a consultant for the National Academy for State Health Policy, Milbank Memorial Fund, Catalyst for Payment Reform, and other important entities. I have been reading and hearing so much about private equity taking over healthcare. This is such an important and timely topic, and I am really looking forward to this talk.
Thank you so much, Professor Hoffman, and to the faculty and the program at Case Western Reserve University School of Law. And I am delighted to be here. It's a privilege and an honor to be invited to give the Elena and Miles Zaremski lecture in law and medicine. And as Professor Hoffman mentioned, I'm excited to talk to you today about private equity and the corporatization of healthcare. So I'm going to start sharing my slides now so you can see on the screen. All right. So what got me looking into private equity in healthcare were surprise medical bills. So these are the unexpected bills that we receive when we inadvertently see an out-of-network provider, such as in an emergency or when you go to an in-network facility and you see out-of-network providers at an in-network facility, usually a physician. So these are generally not covered by insurance, these surprise bills, and they're much higher than in-network services. We started to see a lot of news about patients being hit with these surprise bills. And I, like everyone else, was wondering why were we suddenly seeing an explosion of surprise billing, even though out-of-network balance bills have been technically possible for decades. And the answer, it seemed, was private equity. So private equity was starting to invest in some practices. Like anesthesiologists and emergency medicine physicians, and it was willing to push an out-of-network billing strategy as a source of revenue way more than any traditional healthcare providers have ever done before. What it had done is private equity had identified the possibility of revenue monetizing basically a market for them, and then capitalizing on that payment loophole by replicating that practice across the network. So this led to get at the problem of surprise billing. But I was wondering is if private equity was able to find this loophole and exploit it for revenue, what was the next surprise billing type of payment loophole that's driving private equity investment? Because we know private equity investment has been increasing, not decreasing in the So one of the things I did is I got together with some colleagues at the USC William Schaefer Initiative to try to figure that out. And we mapped where private equity was moving, particularly in terms of its money investments into position practices, to try to figure out what those financial engineering loopholes were drawing all of this investment. And then separately, Mark, Paul, and I decided to write, along with the article, unpacking the legal and policy levers that might be available to address these problems. And that's the subject of today's talk. So here's a quick overview of what we're going to cover today. So first, I'm going to start with just a summary of the trends in private equity investment in healthcare, as well as describe the private equity model. Second, I'm going to identify some of the harms that private equity might pose to patients, to physicians and workforce, and also to the healthcare market overall. And the third, to figure out what to do about it, if we are concerned about these risks, we have to ask what is the revenue strategy, what is the loophole that is driving investment into a particular market segment. And once we identify what the revenue strategy is, what the market failures are, that tells us where to target enforcement and policy change. And finally, I'll discuss some of the potential legal and policy levers that can address the harms and playbooks of private equity investment in physician practices as a case study. So there has been a significant increase in private equity investment overall in healthcare. Private equity capital investment in the healthcare industry grew from about 2,000% in the 20 years between 2000 and 2018, from $5 billion to $100 billion. So over the past decade, we estimated total deal value in current dollars, 2010 to 2020-ish, is about $750 billion of investment. So more recently, the trend has shifted from private equity's initial interest in hospitals and nursing home facilities to physician practices. So private equity investors have targeted physician practices, starting out with just 39 deals annually to 200 in 2010 to about 221 deals annually in 2019. And these investments are not spread evenly across all physician specialties. Private equity was interested in targeting particular specialties. And these specialties belong into three main categories based on, again, their revenue model. One were those hospital-based physicians. These include the emergency physicians, anesthesiologists, radiologists. Then there's another category of what we call office-based physicians. These include dermatologists, ophthalmologists, gastroenterologists, orthopedists. And finally, there are primary care investments and other types of providers that particularly are valuable in value-based payment arrangements. And so as I'll describe here in a few minutes, private equity investors have identified a different revenue strategy for each of these specialty categories. But first, let's just describe what the private equity model is. So the private equity model involves a financial sponsor, and that's the private equity model. So the financial investor is comprised of a general partner, which is an entity that assumes all the sort of key decision-making and legal responsibility for the investment. And then that general partner partners with the money invested by limited partners to invest in private companies, target companies that do fund identities. So the capital in the private equity, the equity rather in the private equity space, is raised from a combination of a small contribution from the general partner, but a very large contribution financially from the limited partners, who are institutional investors, pension funds, sovereign wealth funds, etc. The overall financing structure, however, even though it's called private equity, is primarily debt. So these partners provide about usually 30% equity to a ratio to pull down about 70% debt, which is secured by the assets not of the private equity fund, but of the assets of the portfolio companies that are the target companies. So the general partner generally contributes 2% of the equity, but stands to earn about 20% of the profits in addition to management fees from the portfolio companies. And the limited partners contribute 98% of the equity and earn 80% of the profits. Notice the private equity investment fund reaps the profits that the portfolio companies earn, which in this case are the physician practices. And in return, the portfolio companies receive initial investment infusion in what they call capital, but it's largely debt, when they are different partners with, and what they do is they end up pledging their assets. Now, if you think about physician practice, most physician practices don't have, a lot of brick and mortar assets to pledge. So that often is, if it's not real estate or equipment, it's usually net patient revenues. And so future patient revenues becomes a very important source of securing and paying back all that debt. The overall time horizon can vary, but typically a private equity fund hopes to exit the investment in a very short period of time, usually about 3 to 7 years, making 200 to 400% returns in that initial investment. And the goal is to rapidly increase revenues, cut costs of the portfolio companies, and then sell them in that short time frame for a significant profit. So the 3 main exit strategies usually are to either sell to a secondary private equity buyer, to sell to another corporate buyer, such as a publicly traded company, or to actually take the portfolio company public itself. The fourth option, which is listed here on the slide, is that the target goes bankrupt, and that increasingly seems to be a risk. So in the case of physician practices, private equity investors have used something called the platform and roll-up model, where multiple small companies in the same market are acquired and merged together. So the private equity firm targets a platform practice, which is a high-performing, i.e. high revenue practice, with a desirable market position. Then it grows that practice by putting on multiple smaller practices to really grow the footprint and also the market power of that practice. The bigger company, again, that means that there's going to be more market share that the company can yield in terms of demanding higher prices from payers. But that also means higher revenues, higher profit margins, and also bigger valuations and greater sales potential when the private equity fund sells and exits that investment. So these are highly leveraged purchases, so consolidation and growth is a quick way to multiply the value of that return on initial investment. So private equity sponsors typically, for physician practices, form a management company to manage the operations of all of those portfolio practices. This platform and add-on model also shows how private equity investment position specialty markets leads to greater consolidation of those markets. So for payers and insurers on the purchasing side of this equation, trying to negotiate with a large consolidated practice is difficult. It's harder than negotiating with individual independent practices. And so what we end up seeing is that those prices tend to increase as the market power of these large practices also increase. So another question I typically get is, how is private equity any different than traditional corporate investment? So in some ways, private equity is just the most recent form of corporate for-profit healthcare. It's not entirely different from what we've seen before. However, there are 3 features that distinguish private equity from traditional corporate investment, which have higher or heightened public policy concerns. The first is that private equity investment, as I described, is heavily leveraged. So compared to a regular or typical corporate investment, it adds a significant debt burden to the target company. Second, it operates on a very short time horizon. 3 to 7 years, where is, again, the typical holding. And the other part of this equation means that the exit or the sale of the target company is necessary for the private equity fund to earn its big returns. It doesn't earn those returns unless it sells the company. So it's not looking to hold the company and operate it as a going concern, unlike traditional investors. And this combination of 1 and 2 creates moral hazard. So the private equity firm reaps all the upside of rapidly increasing revenues, but it doesn't bear any risks of liability, any risks of failure, even the risk of bankruptcy, because the debt is loaded on the target company, and the debt is left there. So its losses, if it does experience a loss, is limited to its very small capital investment, and because it's not a repeat player in the industry, or at least its name is not known to be a repeat player in the industry, it doesn't have as much reputational capital at stake. All right, so what's the risk of all of this? There are 3 main risks that policymakers seem to be concerned about related to private equity investment. The first is consolidation in healthcare increases. And this can come from, again, consolidation of market power increase itself, but it also comes from the strategies used to drum up those revenues. That can be upcoding, it can be aggressive risk adjustment. It's basically financial engineering taking advantage of those loopholes. The second concern is that all of this investment has some harmful impacts on patient care. primarily because private equity firms look to reduce costs pretty rapidly upon acquisition. And usually this takes the form in healthcare staffing reductions. And so this cost cutting and staffing reduction has been shown to lead to worse outcomes among patients, add more adverse events, less supervision, and basically potentially lower quality of care. It also can mean that the private equity portfolio companies, particularly when it's let's say a facility, will seek to close or eliminate less profitable services or facilities from the holding. And that's, in some ways, not exactly good for patient access, but also not so good for patient care. And then finally, there's harms to the clinical workforce. This is more anecdotal. I think there's less empirical evidence of this, but we're hearing a lot in the news about physician burnout, about moral injury, and how all of this is exacerbated and driven by the sort of corporatization of the healthcare professional's experience. And so what this looks like is exit from the profession, staffing shortages, loss of physician autonomy, lack of clinical oversight over intermediate practice, nurses and physician assistants. And so the clinical workforce is also seeming to struggle, even though in some ways they're some of the beneficiaries of that initial capital investment. So the evidence is starting to emerge that these harms aren't just theoretical, they're in fact occurring. So here's one study that came out last year that demonstrated that after private equity acquires a physician practice, it's clear that the prices, the volume, and the spending all increase. A separate work by the same group of researchers shows that even though patient and service volume increases, staffing levels do not, particularly physician staffing. So all of this higher volume is absorbed by mid-level providers, but also it might be rushed through or more volume is squeezed into a given day. And there also may be some upcoding involved here, so what we're seeing is not necessarily more services, but just higher intensity codes. These factors can all contribute again to this idea of moral injury or burnout, compromised patient care, and of course higher spending. So separate research shows that private equity acquisition worsens quality. It leads to worse adverse events, particularly in the hospital and nursing home setting. These studies are just starting to emerge, and we don't yet have studies about the effects of quality on physician practice. All right, so in addition to these discrete harms, there's a more troubling trend or harm that emerges from this picture. And that is that private equity investment in health services is driving a trend toward the financialization of healthcare. And this means that investors, financial companies, financial firms are mining the healthcare services organizations to extract wealth for investors. So we often worry about healthcare costs going up because patients, payers, taxpayers can't afford the increased unaffordability of healthcare. But what we're seeing here is that increased sort of cost of healthcare on all of our bills, coming out of all of our premiums, is not necessarily going to more or better patient care. It's not even going to the providers. It may be going in some instances to the pockets of the investors, sometimes a private equity fund or its limited partner. The primary goal of a financialized healthcare system is profit. Maximizing shareholder value, returns for the private investor, these are the primary concerns. The quality of patient care, the access to patient care, certainly the equity of patient care is a secondary, if not basically ignored concern. And cost control policy is anathema, meaning it sort of runs against the idea that our cost control is their loss of revenue. So any effort to reduce healthcare costs from a policy standpoint is directly at odds with investor profits. And that is one of the main problems with the corporatized healthcare system. So what do we do about this? The next step in the sort of analytic approach that my colleagues and I have taken is to use private equity investment as a dividing, basically to find market dysfunctions that we might be able to fix with policy. Robbers rob banks, so the saying goes, because that was where the money is. And the same premise can apply here. Private equity investors target certain market segments and not others because they have found a way to exploit a revenue opportunity. And if we can follow the money and identify the revenue playbooks that are driving, pulling investors into a particular market segment, we can find those market pillars and loopholes and then fashion a policy response to close the loopholes. So this is what we saw play out with hospital-based physicians. So the revenue playbook that motivated private equity investment into hospital-based physicians, which include anesthesiology, emergency medicine, and the like, this was the out-of-network billing strategy that I opened the talk with. About a decade ago, private equity investors like KKR and Blackstone moved very quickly into hospital-based specialties. And what makes hospital-based specialties unique is that patients don't choose these physicians. So their patient volumes do not depend on being in-network with health insurance plans. So private equity have identified a payment control. Emergency physicians can stay out of network. They can demand higher out-of-network payments because health plans are required by the Affordable Care Act to cover emergency services whether in or out of network. And then there's also the possibility that the physician practice or the staffing company can balance bill the patient for the difference between the amount the insurance plan pays and whatever they want to call their full charges. And they can do any of this, or they could, before the No Surprises Act, without losing any patient value. So reports and researchers started to tie the increased use of surprise billing to entry into the market by private equity-backed emergency physician staffing firms, particularly Envision and Team Health. So patients and purchasers were harmed because they were being hit by these huge unexpected medical bills. Payers were seeing their in-network negotiated rates driven higher by the threat of going out of network. And so surprise bills generated a huge public outcry. It prompted dozens of states and eventually the federal government to pass laws to outlaw surprise balance billing. However, before that bill passed, private equity investors poured millions of dollars of dark money, lobbying, and also direct contributions to members of Congress to thwart the law's passage. Although it was, eventually passed and went into effect, it is still being litigated and challenged by some of these same groups. And that was a huge and politically charged policy solution to a problem largely driven by private equity's entry into the hospital-based market. Note, just this past last May, KKR-backed Envision Healthcare, the ER staffing company that was built on an out-of-network billing strategy, announced it would file for Chapter 11 bankruptcy. So this collapse is due in large part to the fact that the No Surprises Act ended out-of-network surprise balance bills. So this is what we mean by a playbook and a policy response. It's not easy, but it is possible. So what's the playbook behind investors' more recent entry into other physician specialties? There's a different revenue strategy at play for office-based specialties like dermatology, ophthalmology, and gastroenterology. So these are specialties that engage in a lot of outpatient procedures, and these are typically reimbursed on a fee-for-service basis. So the revenue playbook here is to maximize steady commercial and Medicare revenue streams, increase cash-based revenue for things like LASIK or cosmetic dermatology, and in particular, these practices can self-refer a number of lucrative wraparound services, physician-administered drugs, pathology labs, physical therapy services, for which they can bill intensively and sort of offer within the practice. These practices can take advantage of certain loopholes, including the way Medicare Part B pays for physician-administered drugs. The strategy here is to capture the market, increase the volume of patients and self-referrals for procedures, increase the intensity of those procedures, and reduce staffing levels, all to increase revenue. There's also a risk that this is leading to increased consolidation in that specialty market. If all the practices in a given region or across a region are rolled up into one giant practice, this can lead to higher prices, unnecessary services, and also potentially understaffed or inadequately supervised care. So what's the playbook for investor interest in primary care? So it seems that corporate investors have figured out a way to exploit the ability to gain coded practices to increase the risk-adjusted payments from Medicare Advantage and other value-based payment models. And that sounds like a lot of jargon, and it is. And this is how deeply these investors are studying the intricacies of each of these markets. So one strategy private equity firms have pursued is to invest in and expand practices predominantly serving patients enrolled in Medicare Advantage plans. And these are the private Medicare plans. Or to combine the private equity of primary care practices with a combined ownership or joint venture with a Medicare Advantage plan. And the revenue strategy here is to extensively code, even exaggerate, the Medicare patient's diagnoses and comorbidities, which directly increases federal payments to the plans and translates to more revenue for the investors. Besides upcoding the risk-adjusted payments, Under value-based payment models, there's a financial incentive to stint on care. So if you hear about prior authorization scandals and how there's a lot of denial of approval of care, there's a risk patients will be denied needed care because of the incentive to reduce costs. There's also an incentive to reduce costs by substituting less expensive providers from physicians. There's also a potential workforce harm as well. Physicians are often required to sign broad non-competes, non-disclosure agreements, non-disparagement agreements, and they are restricted in their ability to speak out if they see problems with patient care or safety, and they also are unable to leave if they don't like the way the practice is being run because of the non-compete. So what do we do about all of these policies, these revenue playbooks? So private equity has shown a penchant for taking advantage of these various payment loopholes. So one policy solution is to simply, it's not simple, it's not easy, but is to close the payment loophole. So as we saw, one example of this was to close the payment loophole of out-of-network power billing, and that was the list price test, right? All the states price billing, that closed the loophole, allowing hospital-based physicians to stay out of network and command higher prices. Another loophole that could be closed would be to change the way Medicare Part B pays for physician-administered drugs. So currently, Medicare's payment for physician-administered drugs under Part B is tied to a percentage of the drug's average sales price, which creates an incentive for the physician to prescribe the more expensive drug among competing options. So for example, the ophthalmology drug to treat wet macular degeneration has several options. Avastin is 40 times cheaper than some of the other options, like Lucentis. They're clinically equivalent, yet physicians make way more money by using Lucentis instead of Avastin because of the payment differential. They get to keep a percentage of the acquisition price or the sales price, then that means that they get to keep more revenue for themselves. So if we change the way Medicare Part B pays for these drugs, then we close that loophole for some of these billing opportunities. Another way to close loopholes would be to increase the Medicare Advantage in coding intensity adjustment. So for primary care practices, this loophole is the ability to increase federal payments to Medicare Advantage plans and to the practices themselves by aggressively coding patient diagnoses. To close this loophole, Medicare Advantage payment policy could be tightened to better account for the amount of risk code gaming that Medicare Advantage plans can engage in, increase their efforts on enforcement to recoup overpayments, and to make the quality bonus payments for Medicare Advantage more meaningful, more difficult to achieve, and also crack down on this risk code adjustment. So one concern, another policy lever is antitrust enforcement. So one concern of the private equity's platform and roll-up model is that it contributes to market consolidation in those physician specialties. So there is evidence that in some localities, private equity penetration exceeds 40–50% of the local market. Because the value of these transactions, though, typically falls below the mandatory reporting threshold under the Hart-Scott-Rodino Act, these acquisitions tend to go unreported and therefore unreviewed. There's really no one necessarily receiving notice that these acquisitions are happening in real time. And so antitrust authorities, it's not that they never know that these are going on, but they often are not notified ahead of time, and so they can't do pre-market review. This leads to consolidation that flies under the radar. It's called stealth consolidation, and we've seen this happen across the country. So at the federal level, one thing we could do is we could change or amend the Hart-Scott-Rodino Act reporting threshold. It can be reduced or eliminated for healthcare acquisitions to a lower threshold level. We can allow for pre-merger review of physician acquisitions by requiring, and some of this is being done through merger guidelines and through some of the rule changes of the FTC, but to aggregate the value of serial small acquisitions to be able to cross that threshold if there is a threshold. To look at the cumulative effect of multiple acquisitions. And recently, of course, the FTC has taken them and has taken some very promising steps to increase antitrust scrutiny over private equity-driven physician roll-ups. The merger guidelines that were just announced this past year in 2023 include a new guideline that antitrust agencies will evaluate serial, cumulative effects of acquisitions not just on an individual transaction basis, but for their combined effect. Second, in September, the FTC brought a major case against U.S. anesthesia partners in Texas and its private equity owner, Welsh Carson, alleging that USAP and Welsh Carson used a roll-up strategy to monopolize the Texas market for anesthesiology, and that was in violation of antitrust laws. So this, of course, this case is something it's not resolved yet, it's still pending, but it sent shockwaves to the industry because it showed that the FTC is concerned about this roll-up strategy as an antitrust matter. In addition, state attorneys general have parallel antitrust enforcement authority, so states could pass laws that require states to be notified of smaller healthcare transactions, and many states have started to consider doing so or have done so. So, for example, states like Washington and Connecticut require notification even of smaller physician practice transactions, and more powerful are the state market oversight programs, such as those in Massachusetts, Oregon, and California, that require not just prior notification, but prior states review and review not just of the antitrust concerns, but also concerns on quality, workforce, equity, quality, etc. So these allow for another sort of window and opportunity for review to supplement those efforts by the federal antitrust enforcement authorities. So another lever is fraud and abuse enforcement. So private equity firms' emphasis on increasing profits of acquired practices may increase risks of overutilization, of overbilling, of upcoding, self-referrals. I've made reference to all of those practices as revenue strategies. So the same pressure to maximize profits may lead to stinting as well on less profitable services or patients and increase the use of non-physicians without adequate supervision. So these threats to patient care and healthcare spending from providers' financial incentives are generally addressed by the federal fraud and abuse laws, including the False Claims Act and Kickback Statute and Stark Law. And stepped-up enforcement of these laws by government and private whistleblowers alike could address some of the fraud and abuse risks posed by private equity investment in physician practices. When private equity firms assume active management control, as they often do through their management services organization, and they do so in a way that puts them in the driver's seat of the profit and revenue strategy of the practices, it may be easier for the government to assert that the private equity firm knowingly participated in the improper conduct of its portfolio practices and actually potentially be able to hold the private equity firm liable for those abuses if they turn out to be violations. So in the fraud and abuse context, the key policy recommendation is to increase federal enforcement under existing laws to penalize and deter private equity-owned companies from engaging in questionable and nefarious billing and fraud practices. Another policy lever involves the states. So acquisition of physician practices raises anti-competitive issues under employment laws and other things that implicate state regulation of licensed professionals. So private equity firms commonly include non-compete terms in their physician contracts that preclude any of the group members from practicing in the area where the firm operates for a prescribed length of time. So these non-competes are not unique to private equity, but because these firms are starting to cover a much larger geographic footprint than a conventional physician practice, the anti-competitive effects and burdens on physicians can be much larger. Employment laws are typically governed by state law, although the FTC also has a proposed rule to ban non-competes, including for physicians. So these state and federal efforts could regulate and limit the scope of permissible non-competes, but also start to take stronger action on non-disclosure or anti-disparagement agreements, often called gag clauses, that prevent physicians from speaking out, or other nurses or other licensed professionals from speaking out if they encounter ethical or quality of care concerns about what some of these pressures are doing to their ability to provide good patient care. The courts have traditionally addressed many of these concerns through what is known as the corporate practice of medicine prohibition. In brief, this doctrine bars non-professionals, like corporate investors, from owning or controlling medical practices. However, healthcare companies and investors have largely figured out how to contract around the corporate practice prohibition. So the corporate owner controls the management of the business, and then it contracts with a professional corporation, which is supposed to control all clinical decision-making and the actual practice itself. To address private equity's ownership and the contractual arrangements between the private equity management services organization and the acquired physician practices or the affiliated physician practices, states are considering legislation to strengthen the corporate practice of medicine, to allow professional practices to maintain more control over not just the clinical decisions, but also key business decisions as well, that tend to be ceded to the private equity firm, often sort of without the knowledge of the physicians at the time. So these are ways that I'm working with states actually right now to advise on some of these efforts to strengthen the corporate practice. All right, one more policy lever, and then I'll get to the takeaways and get to questions. And that is to, most of these policy recommendations we've noticed are not specific to private equity. They're basically using existing tools, maybe sharpening them a little bit, to go after a particular concern raised by private equity. But there are some things that we could do that target private equity firms themselves. The first is to close the carried interest tax loophole. This is the favorable tax treatment that private equity investors receive. And it's noted that the Inflation Reduction Act of 2022 would have narrowed, maybe not closed entirely, the carried interest tax loophole, but Kristen Sinema, as a condition for her necessary vote, insisted that we strip it out. So it's still a work in progress from a policy advocacy standpoint. Another, I think, important tool here would be to just simply increase the transparency of ownership of healthcare entities. So right now it's very difficult, even for researchers with access to very large volumes of data, to be able to tell which positions, which practices are owned or acquired by private equity investors or other types of corporate investors. So transparency and ownership and control, these sort of sprawling networks and complicated business structures that are created can be in some ways hard to navigate. It makes it hard for oversight. It makes it hard for researchers to study the effects. So one simple solution, at least it's not a solution that would solve all these problems, but at least it would help move the ball forward, would be to increase the transparency and ownership and require disclosure of the business structures and ownership relationships and contractual affiliations between these entities and the private equity and other investors. So the final slide is just on takeaways. So I've given a lot of specific information. But if you take away just a few sort of key points, is that we've observed that private equity investors have indeed flooded the market of healthcare. And this is having a result on balance of increasing the financialization of the healthcare industry. And then even though corporate or for-profit medicine is not a new phenomenon by any means, private equity does pose some sufficiently heightened risks that it warrants a policy response. And these are somewhat unique to private equity, but also just sort of a stronger version of what we've always seen in for-profit medicine. The good news is that we have many tools already developed to address the risks of corporate investment in physician practices. Some of these tools need to be dusted off, like the corporate practice in medicine or the sharpening, but they exist, so we don't have to necessarily start from scratch. The legal and policy levers that we've identified exist at the federal and state level. They span every branch of government, right? There's sometimes we need to strengthen legislation, but other times we can do social rulemaking or increase enforcement by the executive branch. Or sometimes there's even a private cause of action that private whistleblowers or private plaintiffs can bring to increase this scrutiny. So there are lots of levers available. The bad news is, however, that ultimately these policy levers may be insufficient to address the corporatization of healthcare overall. There's a feeling of whack-a-mole, of sort of catching up with a market that's moving faster than regulators or policymakers could ever move. And that is, I think, something frustrating, but it's not a reason to just sit back and do nothing. If policymakers want to target this problem, again, that kind of lends itself to an advice that policymakers should target the market failures that can be exploited by, frankly, anyone. Any corporate actor, any investor, even nonprofit health systems, anyone can exploit some of the market failures that we've identified, and the payment loopholes, and the consolidation threats themselves, rather than trying to anticipate what the next particular revenue strategy might be in the private equity space. So to close those loopholes so that nobody can take advantage of them. All right, so with that, I think I'm going to close my remarks, and then I'll just leave it, stop sharing my screen so I can see you, and then hopefully there'll be some audience questions as well.
Okay, so we definitely have some questions. I'm going to actually ask the first one.
Sharona, I think you're muted.
How did I get muted? Is there somebody back there? I'm unmuted now.
You're unmuted, yes.
Okay. So I have noticed that it's getting very hard to get a doctor's appointment, that if you call and you say, I have 101 fever and I'm dying, they say our next available is in 3.5 weeks. And if you want a specialist, you're in real trouble because their next available is in 6 months. Is that related to private equity as well, or is that just physician shortages, or what's going on?
I think it's a really good question. I think it's probably related to a larger phenomenon that isn't, again, restricted to private equity, but it is sort of this notion of sort of combining practices. Reducing staffing is like a common strategy, not just for private, but also for Optum and payers and others. And so I think what we're seeing is the sort of potentially, it might be the physician and nurse shortages, the burnout effect, right, of all of these changes to the professions. But also I think it's part of the strategy is to streamline operations and cut costs. I think means that things like immediate appointments and availability of physicians appointment times are just, within your area or within your plan network is getting harder. I think that is something that we're seeing. It could be a result of consolidation, right? So, entire networks are sort of negotiating together. If you don't have access to that network, it's very hard to find, other physicians who will see you. But so I think it's sort of all related, and I can't tell whether that's both a result and also part of the strategy itself.
Okay, Anat?
Yes, so I wanted to thank you. I teach business associations at Case. I'm Anat Beck, and I see a lot of my students here. We talk about private equity. So in my previous life, I used to do M&A and represent venture capital and private equity. And I'm not surprised we're seeing this consolidation. Actually, with the current market conditions, I would expect to see more. But as you noted, two things, and I'm wondering what's your take on them. One is with regards to regulators stepping in. So we are seeing more consolidation. We're seeing the FTC and DOJ going after some of these. And you're saying advocating for more disclosure of ownership. But how is that going to take place? Who are they going to disclose to? As you know, private equity is in the private markets. So those are markets with asymmetric information, and the disclosure is problematic here. Who are they going to disclose to, and what do you think the FTC is actually going to do here going forward, and the chilling effect, or what should private equity funds do in the future if they're looking into acquiring? Are they just going to use shells, right? Are they going to do different types of mergers? That's one. The second is with regards to really even here in our community, we have Summa Health that's been on the news. So it's going to affect our community as well. Here we actually have almost two very large healthcare systems. We have UH and the Cleveland Clinic, and now Summa that's being considered to be acquired by private equity. So I don't know how that's going to affect the other two dinosaurs that we have here, which is the Cleveland Clinic and UH. And I wonder what's your take on that? And just a third one.
Okay, maybe we'll stop at 2 because there are other people. Go ahead.
We can follow up after and have a longer conversation because it seems like there's a lot there. I'm happy to take these two questions. So one is, how will the increased disclosure work, and will that and how might that implicate some of the both opacity and also sort of the stealth consolidation that we're seeing in the market? I think so. One of the things that we've advocated for is certainly that, yes, it's one thing to sort of require more transparency of the private equity firms themselves. That has run into a lot of, even small efforts in that direction by the SEC has run into a lot of resistance, obviously, by the private equity industry. And so one of the things that we're advocating is that the physicians that every sort of provider who participates in Medicare or Medicaid needs to file sort of provider identifier information with CMS and HHS. And so part of that is to find a way to, for at least the physicians, although this might create burden on physicians who may not know. Like I don't know who owns, the management services organization that essentially runs my practice. And on paper, they look like they're still owned by a group of physicians or one physician with a license, but for all intents and purposes, operationally, they're contractually operated and controlled by a management service organization. So trying to figure out sort of how the entities themselves, the practices or the MSO, can illustrate and provide some feedback to the federal healthcare agencies. Of course, making that public and making that available to researchers will be important. And then from the FTC has the new Hart-Scott-Rodino rules that came out last year that will require a little bit more information from reported transaction entities about prior transactions, about business structure. So there is some information that might be collected by the FTC there, but it's only triggered when you have a Hart-Scott-Rodino filing. So again, you have to be above that threshold to even be required to notify the FTC. So I think that is, one way, and then, there's the Corporate Transparency Act that's also applying to some of these companies, and there's, again, some complicated loopholes that just went into effect. So there's lots of effort on transparency. I think that's great, but it also needs to be aligned and it needs to be effective transparency, not just additional reporting requirements on companies. On the question of what do you think might happen to Summa Health if it's acquired by a private equity company, I don't know if anyone's been watching the news in Massachusetts, but there's a lot of news about Steward Healthcare operates 8 hospitals in Massachusetts, and those hospitals are teetering on the brink of closure, basically, financial disaster. And so there's a lot of concern about whether this is part, again, of the playbook for private equity investment in hospitals, which is typically a different playbook than physicians. They strip the hospitals of all of their assets. They sell the land, the buildings, the real estate to a REIT, a real estate investment trust. I don't need to tell you this and that, but, and then leverage, then load all the debt, servicing the debt falls on the hospitals, and then if they can't keep up with those debt payments, that's what pushes them into financial distress. So there is some concern. Regulators are looking, but I don't know if there's anything to do necessarily in Ohio to stop it. Some states have the ability for the AG or a healthcare commission to study the effects of a merger and stop it beyond just taking an antitrust action, but I don't think Ohio has that as authority. So many states are trying to increase that authority.
Thanks so much. So the CLE code, for those interested, is 534510. 534510. And do we have any virtual questions? Why don't we take one of those? Aline, can you please?
Somebody asked,
Are
any private equity firms trying to keep these health policy issues in mind, any that are trying to do these investments in a more ethical and equitable way?
Yeah, I think, I'm not going to name names just because I'm not super confident in my ability to recall all of their different names, but there's a lot of variation in the private equity landscape. So they're not, I hate them to be sort of like a troubling presence in the healthcare space. And there are some that I think are trying to take a different approach, like to hold longer, to not do the 3 to 7 year exit. And so I think that there are some private equity firms who say, don't paint us with the same brush as some of the biggies who are getting their names splashed across the headlines. But I think the question is still whether or not the revenue incentives are still there. I mean, there's still an incentive to cut costs. There's still an incentive to increase revenues. Even if they plan to hold the company longer, it's usually still financed largely through debt. And so I think the fundamental structure of the private equity investment contains this risk of moral hazard, even if the intention of the investment management services organization is to run a more patient-oriented practice or healthcare facility. But I think that, just sort of as a general trend, yes, we're concerned. But of course, are there individual exceptions to that? I'm sure there are.
So Professor Melman has a question.
Hi, Erin. Good to see you again, and thank you for an excellent talk. So you mentioned the enormous lobbying power of the private equity industry, including in the healthcare sector. And I'm wondering what are countervailing political forces that might achieve some of the developments that we need. So I know the American Academy of Emergency Medicine, and I look forward to seeing you on Saturday in California at their meeting. But what is organized medicine doing about this? Are employer groups weighing in against this because it increases their health costs and so forth? What is the AMA doing?
So, yes, I will see you this weekend at the American Academy of Emergency Medicine Summit. That is probably one of the more organized physician groups, sort of on the flip side, and Take Medicine Back. So Take Medicine Back from corporate interests is their sort of rallying cry. But I think that there's sort of not a well-organized other side, right? There's some group that's really telling the other the concerns it's diffuse, right? We have like patients and communities on the one hand, and then different physician groups, some of whom feel chilled by their onerous employment agreements and contracts, and so there's sort of an unwillingness to speak out as a general matter that we've seen. The AMA, interestingly, I think at the behest of Take Medicine Back, and some of this, did consider adopting a resolution to urge a larger sort of federal version or larger commitment to corporate practice of medicine prohibitions. But the AMA, which has its own colorful history about the corporate practice of medicine, usually it was a proponent of corporate practice of medicine back in like the early 20th century. But its position has changed. So despite the sort of like scramble to try to get the AMA, it was split, and the delegation at the AMA decided to basically table consideration of a corporate practice of medicine recommendation. And I think that might reflect the fact that there are physicians within leadership at these organizations on both sides of the issue. So while you see physicians who are sort of the rank and file, the ones who are seeing patient care and getting kind of bulldozed by this trend, there are others who are sitting in management. And they're the ones who are investors, and they're the ones who've been picked to be this, CEO of the MSO, or they're being paid by Amazon, or they're being paid by these private equity companies. And so to be the medical director of all of these platform practices. So I think that might reflect the fact that there is a mixture of sort of management and labor in the AMA at the moment. I can think of one other potential source of pushback, Professor Bowman, would be there's a large sort of lobbying effort, sort of like workforce mobilization. Of course, nurses have a strong and powerful lobby, but I think physicians are increasingly turning to lobbying, sort of unionization as well, and organizing as a way of kind of pushing back as a group against some of these larger trends. So.
Okay, Shelby, why don't we take another one online? And we only have a couple of minutes, so.
Are you seeing similar trends in joint ventures between hospital systems, some of which are nonprofits, and private equity?
Yes, I mean, I think that the hospital private equity trends, that sort of started before the physician one, frankly. So hospitals have been targets of private equity investment, but as far as the joint ventures, yes, I think those continue. I do think one of the things that there's like, people sometimes call me and are like, what's the next, area of private equity? And I respond to what the market's doing, but I hear that, behavioral health is an area of concern, home health, hospice is hot, telemedicine, and then certain new practice areas are things like cardiology. And so I think one of my next questions, particularly for behavioral health, is what's the revenue play for behavioral health? Because that's, that sort of, just those two things put together, private equity, behavioral health, makes everyone a little bit non-punished. So I'd like to kind of get to the bottom of that. But yes, I do think that the private equity is somewhat moved on to the hospitals, but not.
Well, thank you so much. This was a great talk, a great way to start the semester's Zaremski series. Please look at the Law Medicine Center website for our additional programs. We have quite a number of them. And thanks so much, Erin. That was just very illuminating and thought-provoking. And unfortunately, we have to end because people like me and many others have to go to class now. So, thanks so much.